So I'm Tim Denison. I'm a professor in engineering science and clinical neurosciences. You can probably tell from my accent. I moved here from Minnesota in the Twin Cities in the United States. I worked in industry at a company called Medtronic for 15 years and then came over 7 years ago as a chair in emerging technology sponsored by the Royal Academy of Engineering. So my talk today is going to give you a perspective within the biomedical engineering panel. And I specifically chose a topic to show you research interests that students have and the kind of projects that they work on. And so we have two cities that we're going to think about and how the neurotechnology that we create for these cities is quite different, even though we're going after the same challenge, which is coming up with solutions with people who are suffering from epilepsy. So engineers, we always like to motivate ourselves with tough problems that are important. And just to give you a snapshot, this is a picture of different diseases. This is from the perspective of the EU. So the diseases are listed here. The top row is the number of millions of people suffering from a disease in a given year. The middle row is the cost to treat them, the direct costs within the health service. And the final row is the aggregate costs. And so you can see in areas such as anxiety disorders, mood disorders, and depression, we're talking about many tens of millions of people and a cost burden on the health service on the order of 100 billion euros per year. So even the areas of epilepsy, which we're going to focus in on today, we're still trying to deal with patient populations, over 2 million, and with the 14 billion annual direct costs. But this is only the direct economic costs. We also have to think about the impacts on the family, on the care circles. And so these are problems worthwhile for engineers to think about. And we'll talk about how we go about it. Now, one of the things that we try to reinforce in the engineering science department here at Oxford is kind of a whole systems solution. And so in your first couple of years, you'll get the core principles of technology across all the disciplines, which is important, especially in biomedical engineering. There's fluid mechanics, circuits, control theory, core science, as well as understanding unmet clinical needs. So are we identifying and addressing the right problem? But the other element is we include engineering ethics, thinking about regulations, human factors and workflows, as well as economics. And so we round out the curriculum with some of those practical, pragmatic things that are actually really required to take an engineering idea from the concept in the lab all the way out into society. So even engineering ethics, when you build a bridge, you're going to build a bridge over the river, what are the safety factors that you have to consider? What are the transparencies, understanding the weaknesses of your design and making those transparent to the user? All of these are actually general across all disciplines. But in the area of biomedical engineering, we're going to talk about a brain implant that are going into children, as well as a diagnostic system for Zimbabwe. And all of these elements come into play. And that's what it takes to actually truly have a successful bioelectronic or medical device. So let's start thinking about epilepsy. Why do we want to come up with solutions for epilepsy? Well, just in the UK alone, there's 600,000 people who are suffering from it at any given time. 1/3 of them do not respond to medication. So in spite of all the pharmaceutical opportunities out there, they're still not having seizure control. Why does it matter? So imagine that I randomly selected one of you. So I'm going to close my eyes and point, and then I'm going to ask you to lay down on the floor, have convulsions, black out for 2 minutes. So just the thought that I might randomly pick you maybe raises your anxiety, and that's just to give you the smallest amount of empathy for what a day is like for these people. They don't know when a seizure is going to come on, and so that's a real issue that we have to try to seek to address. The annual cost to the NHS, as you probably see in the news, the NHS has a stress. It's about 1.3 billion pounds. But our opportunity is that we can go in and do early treatment of epilepsy. And if we get in earlier, we can actually change the life course for the children and for those families. So keep kids in school, allow them to get jobs. That's our ultimate objective. And part of the engineering motivation is that there are very good biomarkers. We can actually sense things. The opportunity for us is to figure out how do we optimize treatment. Now, the other thing is I'm wary when we say 600,000 people, millions. These are all lost in statistics. And so I'm actually going to walk you through a case study with one of our participants in the research, hearing the perspective from his mom. And this is actually a story that was done by Fergus Walsh at the BBC. You may have seen it a year ago, but we're going to hear first from a young man named Oren and his mom and her perspective.
He's 12 years old. He has autism and ADHD. But what is holding him back most is his epilepsy. He's not had a day without seizures since he was 3.
I have a very bright and up together 3-year-old that within a few months of seizures commencing, deteriorating rapidly and lost a lot of skills. So this is a tonic chronic.
Oren has multiple seizures day and night.
So this is his worst seizure, a tonic-clonic.
He stops breathing.
And oftentimes he has to be taken to the emergency room and resuscitated.
Epilepsy seizures are triggered by abnormal bursts of electrical activity in the brain. These can often be controlled by drugs, but Oren's form of epilepsy, known as Lennox-Gastaut syndrome, is so severe nothing has helped.
Every movement is like affected because of his epilepsy.
Is it robbing him of some of his childhood?
It's not doing all of his childhood so far. I want all of that. I want the child that, or at least memories of the child that I remember. I want some of that back. I want him to find himself again.
All right. So that's the perspective of one mom taking care of her child. And that's a fairly universal experience across the globe. And that's going to motivate, both what can we do in London and also in places like Harare with different needs. So starting out in London, if you actually present with epilepsy in the NHS, you'll have a good chance of getting a prescription. So if you're going to respond to the medications, you'll be in a good shape. Oren's one of those children with one of 3 that actually is refractory to medication. So we need to think of other ways that we might be able to help him. So what we are looking at is applying electrical stimulation. So electrical stim has been known to interact with physiology for quite some time, back to Galvani and Volta, where the volt comes from, and the inventor of the battery. They could reanimate frog legs, make them twitch, and those same principles have been applied and adapted, especially since the 1960s when transistors came around, to provide very targeted, focused electrical stimulation to the nervous system as a therapeutic agent. And so to give you a sense of its impact, this is a gentleman who suffers from essential tremor, and on the left, he has a device, and it's been turned off, and on the right, the device is turned on. So you can see as he goes about his activities of daily living, with the device turned on, he's actually able to draw a little bit better. He's able to hold a glass, kind of take care of himself. And so this is what the electrical stimulation is doing. But now, what's going on inside of him is that he has what's essentially a brain pacemaker, is one way to think about it. So we've modified what was historically a cardiac pacemaker with the electronics and the energy source, the battery that's implanted in the chest. But instead of routing it into his right heart to pace his heart, the surgeons are routing up the electrodes and putting those contacts deep into the brain, into specific areas and networks related to the disease state. So in the case of tremor, they're in the thalamus and a part of the circuit called the basal ganglia that controls motion. And we want to take that same technology and think about what can we do to adapt it to treat epilepsy. So what's happening with that electrical stimulation is we're kind of modulating the information flow, and we can kind of break up these really bad oscillations. That's the kind of the hypothesis. And we think, what can we do with an epilepsy? So in the case of epilepsy, like in Oren's case, he has what's called generalized epilepsy. So basically his entire brain starts to go through this seizure and convulsion. So think about it intuitively. If you want to have an impact on a large network, like the railroad network of England, if I want to help the trains run on time or disrupt them, I can go into King's Cross or Paddington, that central station, and have major impact on how the entire rail network operates. It's that same intuition that in Oren's case, we go into the central median thalamus, this blue hub, and by putting a little electrode right into that major station, we can stimulate and modulate the electrical activity and have this impact that's fanning out across his entire brain. So that's the intuition of the surgeons coming in, placing that electrode there, and then adjusting the modulation. Now I showed you that device, the X-ray. What's the challenge? We want to go down to children who are down to the age of 5. So does anyone see a problem with implanting a device that was designed for a male in their 70s, a typical Parkinson's patient, for a 5-year-old? Any ideas? Scale? And what's a big difference between a 5-year-old and someone who's my size?
The brain's not necessarily fully developed.
Yeah, the brain's not developed, and even more practically, they're going to grow. So when I was 5, I was probably about this size, and so the growth is a real problem in these devices. And that's something we think about, is that really devices, oftentimes people think, well, children are just adults in miniature. That's not the case. They actually have their own special needs. And so we think very carefully, the students who work with us and the companies who collaborate with us, about what are the issues with children that they're going to uniquely face. And a big one is thinking about the extension. This is that electrode going through the neck. That's going to tend to break. Or you have to go in for multiple surgeries and keep readjusting the implant as the child grows. We also need the devices to last a long time. So another difference of a Parkinson's patient is, unfortunately, they probably don't have much long of a life left, on the order of a decade or so. Children who are 5 could have 70 plus years left. And so the device has to actually last for a long time. And so that gets into rechargeable systems. So these are the kind of, our students actually wrote a paper in the Lancet, talking about what does a kid-friendly device look like, making it child acceptable, making it rechargeable so it'll last a long time, but also this remotely programmable and adaptive. It's just like your smartphone, or those of you familiar with smartphones and the like. We can push out adjustments. So you get that notification, new operating system is ready. As we learn new science and new ways to treat patients, we make sure that the device can actually be upgraded as well. So it's very similarly, we have a wireless update that allows us to improve the system. So this is what it looks like as a cartoon. So this is actually the implant itself. It sits in the skull, so it goes into a little pocket. And then the surgeons hook up the leads and they go into that central thalamus target. And then we, as academics, work together on this algorithm toolbox. So think about how can we adjust the device based on circadian patterns, the natural electrical signals that are flowing through the brain, and the motion, kind of how people move around and the like. So let's now step in. Let's check in on Oren, our first patient with this, and he's in the OR. So,
it's October 2023. Oren is being prepared for major surgery.
So this is the robot. They're configuring the robot, which will help to arrange where the leads go.
In the world to trial this device, a neurostimulator, which will sit in his skull. The number one, right?
So that's Martin. He's the lead surgeon and runs the project.
Electrical impulses deep into Oren's brain via 2 electrodes. The leads have to be inserted into the thalamus, a key relay station in the brain for sensory information.
So there's a wire in it now to help to put it in, and then they pull that wire out, and it goes floppy.
Millimeter perfect precision.
So this study is actually going to allow us to identify really whether this is an efficacious treatment for epilepsy.
That's me, just in case something needs engineering support, which luckily I look bored. That's the best thing. I should not be doing anything. I'm only there in case something goes wrong.
After inserting the electrodes, they are carefully